Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium. Thank you.
So thank you very much for allowing us to be here today. We appreciate this invitation from the Lymphatic Education and Research Network. My name is Denise Adams. I am a pediatric oncologist, and I have been doing vascular anomalies now for almost 20 years. I am now at the Children's Hospital of Philadelphia, but also have been part of the vascular anomaly team at Cincinnati Children's in the past, and also Boston Children's Hospital. And we have also a wonderful person, Kimberly Steele, who is an MD PhD. She is a surgeon who has a son with a vascular anomaly and also works for the LGDA. And when Kim talks, she can introduce herself as well. Today, we really wanted to talk about the journey of lymphatic anomalies. I had the pleasure of speaking with you a couple years ago on lymphatic anomalies, where we went over the classification system. And I today wanted to talk about where we have come with lymphatic anomalies in particular. So I'm going to tell you a little story about our past to the present. So I do have some disclosures. I'm a consultant for Venthura, who is helping us develop some new applications in developmental therapeutics for vascular anomalies. And I'm also a consultant for Novartis, and all the drugs that we talk about will actually be off-label. So our outline is I wanted to describe to you sort of a new entity called a vascular anomalist, and that's what we are. So we come from many different backgrounds, but we take care of patients with vascular anomalies, and so lymphatic anomalies fit into that picture. I'm going to talk a little bit about the classification system, but this is going to be a series of talks, and you're going to learn more about the classification system in these talks, which is going to be wonderful. And then we're going to talk about lessons learned, and we always talk about how we can learn from just one patient, and Kim's going to give you a personal story about that. But we're going to focus on how we've taken 3 stories and we've learned from 3 patients how best to treat lymphatic anomalies. We're going to talk about genotype-phenotype discoveries that we've made in the field of lymphatic anomalies, and also talk about how important collaboration is in our thoughts for the future. So to me, when I go back and think about what it is to be a vascular anomaly specialist, I start with a journey that I had when I was a fellow. And this was back in the late 1990s when I was a pediatric oncology fellow at Duke. And I started seeing these patients with vascular anomalies in a clinic that I had, because it was the same day that a dermatologist had a clinic. And I was sent many patients that had a very different look to them. So we call that the phenotype. So what your clinical exam was, what the radiology is, what also the pathology could be, but they were all given the same diagnosis, and it incredibly frustrated me. So at the time that I started, when I went to the literature, what I found was just pattern recognition, a very simple classification system, some surgical and interventional treatments, but not a lot of medical therapies. And the medical therapies were being used for every single diagnosis. There were certainly no clinical trials, and there were no cooperative groups like what we had in oncology. But now I can say that we have a much better classification system. We actually have some standards of practice. We have multidisciplinary, or what we call interdisciplinary centers, where people see patients together. We have medical therapies, we have better phenotypes, we can link them to genotypes, and we now have clinical trials that we're starting, and we also have things like biomarkers. So back in 1982, John Mulliken, who's a plastic surgeon in Boston, created a very simple classification system where vascular anomalies were tumors, and tumors were things that were proliferating. They weren't all malignant. In fact, the majority of them were benign. And then malformations. And malformations were described as low flow. So a lymphatic malformation would be a low flow malformation versus high flow, and a high flow malformation would be something like an arterial malformation. Then there's a group called the International Society for the Study of Vascular Anomalies. And I have to say, when I first got interested in this, I was one of 2 hem-onc physicians that were part of that group, and that was like in 2002. But this group has gotten together. The last meeting that we had, the last ISFA meeting, there were 150 hem-onc docs, and many more basic scientists as well. So ISFA got together, they formed a scientific committee, and they decided that we really needed to revamp the classification system. We needed to think about what our phenotypes were. We needed to think about if we had genotypes. And in 2014, this was published in Pediatrics. And what we improved is we improved on the phenotypes. We presented new diagnoses, new anatomical variants. We introduced the names of specific syndromes, and some of these were in the lymphatic world. We noted the known and accepted genetic causes, and this classification system was updated in 2018, and in the next 2 years, this will be updated again. So we went from a classification system that was a single page to a classification system that is over 14 pages. And anyone can look at that. They can go to the ISFA website, and there's a spot in there that you can actually look at and download the classification system, and I think it's very important. So when we think about lymphatic anomalies, and I'm going to just go through this in a very limited way, and you'll hear again about this in the next talks that we have, we can divide lymphatic anomalies into tumors, and we can also divide lymphatic anomalies into malformations. So when I think of some lymphatic tumors, one of the biggest ones is a tumor called Caposiform Hemangioendothelioma. And this is a tumor, this was one of my first patients that came to me when I was at Duke. And it came to me with a diagnosis of this being a hemangioma. But this patient's platelet count was 3,000 and her fibrinogen was undetectable. This is an intermediate malignancy in the WHO, and it's based on a spindle endothelial cell, but it is lymphatic derived. So these tumors are positive for D240 and PROX1. It doesn't really have any metastatic potential, but initially, before the drugs that we have now, 20 to 30% of patients would die of hemorrhage or multi-organ system failure. This is a patient that I took care of way back when I was a young attending, who had an ill-defined lesion that in retrospect, and people re-looking at pathology, wound up having an infantile lymphangiosarcoma, which is really extremely rare. And so we also do see malignant tumors when we're talking about the lymphatic system. So basically, when we talk about lymphatic malformations, there's a lot of heterogeneity, as you can see. So this over here is a patient that has what we would call, and I don't think anything should be called simple, and that's one of the things that we're going to change from the classification. But this is a focal or a local lymphatic malformation that's made of a large cyst, and so that's called a macrocystic lymphatic malformation. This patient too came to me when I was a fellow, and the diagnosis was a hemangioma. And this, again, was not a hemangioma. This was a lymphatic malformation, and this patient actually had an infection, and that's why you see that it's red. Versus this lymphatic malformation, which I would not call simple, but it is in one area. This is a head and neck lymphatic malformation that is microcystic. So there are very rare macrocystic lesions. This is mostly a microcystic patient, and you can see the difficulty in treating this patient. This other patient has a combined lesion. So this is a patient that has a capillary lymphatic venous malformation, but it's mostly lymphatic. And some of those patients are called Klippel-Trenaunay. This patient here has a very complicated lymphatic anomaly, and we call these complicated lymphatic anomalies. This is a patient that has an extreme amount of bone loss, and this patient has something called Gorham-Stout disease, which leads to massive osteolysis. This is a patient that has a generalized lymphatic anomaly. So you can see lymphatic malformations in the bone, but it doesn't cause osteolysis. The cortex is intact, but you see many bone lesions that are lit up on this MRI. This patient also has an effusion, a bilateral effusion. This patient came to our oncology service and they thought this patient had a malignancy. And then going over further to the more complicated lymphatic anomalies, this is something called Caposiform Lymphangiomatosis. This is a very significant, highly morbid diagnosis where patients can have pulmonary disease and other disease where they have activation and proliferation of their lymphatics. They have focal areas of spindle cells, so like the Caposiform Hemangioendothelioma, but there are focal areas of spindle cells. And then this is a patient that has a collecting or conducting lymphatic, a central conducting lymphatic anomaly. We sort of think of this as a problem of the plumbing. And you can actually see from that picture that the thoracic duct is very tortuous, and there's a high amount of lymphatic fluid that's going through that thoracic duct. We know that these patients can have complications. And so you saw from the pictures that there's a lot of heterogeneity amongst them, and they can have many different kinds of complications. So we talked a little bit already about the infectious complications that you can have. They can have bleeding complications. You can, again, have problems with your bone and soft tissue that causes pain and swelling. Lymphatic malformation patients can get these lymphatic blebs that can bleed and also get infected and can be very distressing and painful. You can have effusions, chronic lung disease. You can have dilated veins or ectatic veins that can thrombose and even cause pulmonary emboli that are associated with combined lymphatic malformations. And you can also have the coagulopathy that we talked about, the thrombocytopenia, and also the decrease in fibrinogen. So we can have a problem with blood clots, and we can also have a problem with bleeding. So we're talking about the history of these diagnoses. So what were our treatment options? I told you in the beginning that one of my frustrations were the treatment options because we really didn't have a lot of treatment options. And what we used for things like hemangiomas, we used for everything. And that just didn't make sense to me. So I called it the grandma's secret ingredients, or our kitchen sink approach to taking care of vascular anomalies. And so particularly for lymphatic anomalies, we've used steroids in the past. Steroids don't really treat a lymphatic anomaly, but they can make the swelling better. Because propranolol was used for hemangiomas, we use propranolol for lymphatic anomalies. And there is some basic science literature that maybe propranolol does help, but not as much as the other types of patients. Vincristine has been used, and I do not think that vincristine helps at all for lymphatic anomalies. And interferon was used for lymphatic anomalies a lot in the past, and sometimes interferon was used in young infants. And so, alas, here is the problem with that chicken soup attempt. So when we use things to treat many different things, we have to be really keenly aware of what the short-term side effects are and what the long-term side effects are. We are keenly aware of this when we deal with oncology patients. And when I first started this, I'm not sure that we were aware of this when we were taking care of lymphatic anomaly patients and other kinds of vascular anomaly patients. So we learned that interferon in children less than 2 years of age can cause spastic diplegia, and sometimes that does not go away. We also can see the effects that we were having with steroid therapy. And then in our journey, there was a patient that made a difference. And so this is part of the conversation of the power of one. And this has been presented. So I know that many people on the call may be quite familiar with this, but this is a patient that came to see our team in Cincinnati because this patient was given an injection in a leg that had a small bruise. This patient wound up after the immunization having a significant worsening of her leg. So it looked like this. And there was a very astute hematologist oncologist who was in West Virginia who diagnosed this patient as having Caposiform Hemangioendothelioma and transferred her to our care. This patient underwent what we felt was our standard of practice, but was not getting better. And it was to the point that every blood vessel in her body was enlarged, and her heart, she was going into heart failure. At the same time that this patient came in, we had been working with basic scientists to try to think about what pathways could be involved in our patients. And so I was working with a nephrologist who was taking care of tuberous sclerosis patients, and tuberous sclerosis patients can get angiomyolipomas. Angiomyolipomas is a very vascular type of vascular tumor. And we know that mTOR inhibition significantly improves these tumors. And so this scientist and I had been talking about mTOR and this PIK3CA pathway as a potential thing for us to look at in the future. So with a pathologist, we started to test some of our specimens to see if the mTOR pathway was involved. We also knew from this pathway that patients with P10, so P10 is a tumor suppressor gene, which is usually a germline mutation, but P10 patients, 50% of them have vascular anomalies, and they can have lymphatic anomalies. Also, TIE2, which is up above in this pathway, can give you germline venous malformations. And so we had reason to think that this pathway was involved. And for this patient was going through our repertoire of what we felt was standard of practice and not getting better. We actually were adding things like Avastin, which is a VEGF inhibitor, to her regimen with some improvement, but then she significantly worsened again. And so we needed something for what we called palliation for her because her family did not want to give up. But we did not want to keep her in the hospital forever. And so we were thinking about what else could we use to see if we could improve her state. And so we thought of sirolimus because sirolimus is an mTOR inhibitor. It's part of this pathway. Our hypothesis was that this pathway was involved. It was an oral agent that she could actually go out of the hospital with. So we got together in a tumor board. We set up a protocol for this. We talked to our IRB about it. We did not need an IND because we knew the FDA excluded us from that. And so we used sirolimus for this patient, and you can see what happened to her leg. So her leg, which was huge, and she was in heart failure, got better. But the most important thing that happened to her was that her platelet count normalized and her fibrinogen normalized. And we had a rule in Cincinnati that if you treated 3 patients with a particular medicine that was sort of new to that medicine, you had to start a protocol. And so we started a protocol. We were very fortunate at the same time to apply for an FDA funding, so for FDA orphan drug trial. And we received that. We started the protocol initially in Cincinnati, and then we added Boston to it. It was for all patients with complicated vascular anomalies that were mostly lymphatic in nature, because the information that we had back at this time was that probably the lymphatic malformations, this drug would work better for those patients. Overall, we assessed our response at 6 months and then at 12 months into the therapy. And we found that so our definition of response was based on oncologic diagnoses, and we didn't expect anyone to have a complete response because these were congenital problems, but we found that 85% of people had a partial response. And I'm going to show you some pictures of what partial response is, because you might say, this is overwhelming, this looks like a complete response, but you see in the end of course 12, there's still some enhancement. So this was a KHE patient who had response, this was a skin KHE patient who had response, and this was also one of those head and neck, you see that the child has a trach, lymphatic patients that had micro and macrocystic disease. So you see that this patient here would have had a very hard time with the surgical procedure versus at 15 months after sirolimus. Since that time, there have been over 100 papers that have been published on the efficacy of sirolimus for vascular anomalies. And again, really focusing on the lymphatic types of vascular anomalies, but there's also a group in Europe that's focused on venous malformations. And we finally have some scientific background to this as well. And this is sort of what we were missing before. But sirolimus is really not enough. We need an armamentarium for our patients. We know that our patients have many different phenotypes. We know that our patients now have many different genotypes, which we didn't know about. And this was something that, you know, if I think about this and this diagram, it still gives me goosebumps, because what we were trying to find was some basis and some knowledge to know the phenotype and link it to a genotype, just like we do in oncology. And about halfway through that protocol, there were scientists up in Boston and other places that said, you know, a very small percentage of these are germline. So the other patients have to have somatic mutations. Let's look at the tissue of our patients and let's test to see if a pathway is involved. And this pathway was involved. So you can see from this picture on the outside are all the phenotypes or the diagnoses, and they're linked now to the genotypes. So what does that mean for us? And we're going to take it from one side of the pathway to the other. What it means for us is we had mTOR, so we had an mTOR inhibitor, which was down at the bottom of this pathway, but were there other drugs that we could actually use to take care of these patients? And this is a story about a syndrome called Proteus, which is sometimes confused with some of our diagnoses. So Proteus is based at the elephant man had Proteus, and Proteus gives you overgrowth. And the problem with Proteus, it's a problem with the AKT gene. And there are medicines that can inhibit this AKT. And there was a medicine that was used for breast cancer, and a small pharmaceutical company had an interest in moving this medicine forward and found the Proteus patients and thought that this could be good for Proteus patients because they had an AKT problem. They also found from the people at NIH that patients that had PIK3CA mutations, and some of them being lymphatic anomalies, also had upregulated mutations, meaning they made too much of the product of that PIK3CA, and these patients could also be used in this study. And so they had a study that included not only Proteus patients, but also patients with PIK3CA-related overgrowth syndrome. The interesting thing is that we found from this study that we don't need the dosing that we need in cancer. We can get away with a sixth of the dose that's given to oncology patients. And so we don't have as many side effects. And so this is what was happening. We were blocking AKT. And so this trial was opened initially in Boston, and now it's at other sites. This is a patient that had a lipomatous lymphatic infiltration of the abdomen and retroperitoneum. This patient could not eat and had a G-tube, and 7 months into the study, we were able to not use the G-tube. And also you can see he had a decrease in the abdominal girth, and he started to eat. Unfortunately, this study, this pharmaceutical company was bought over by a larger pharmaceutical company, and we're not sure if this drug is going to move forward, which is very sad. So now I'm going to tell you another story, and this is another story about another patient who went to see a nephrologist in France. This nephrologist was actually working on the PIK3CA pathway, but because he was a nephrologist, he had a patient that was going into renal failure that had a venous lymphatic malformation with some capillary component to it. And this patient had a known PIK3CA mutation, and this physician looked up what PIK3CA related overgrowth syndrome was, found that it was, again, a PIK3CA related disorder, looked up PIK3CA inhibitors, and found a medicine called alpelisib, and got that medicine approved for his patient and then 19 other patients. And actually, he now has treated almost 90 patients, again, under the premise of PROS, or PIK3CA related overgrowth. And you see what happened to this patient before and after. So now we not only have mTOR inhibition and AKT inhibition, but we also have PIK3CA, and you see all the phenotypes that are related to that. So let's go over to this other side of this diagram, because this is something that opened up another world to us that we did not even know about. We thought lymphatic anomalies would be all over on the PIK3CA side, but you can see that there are some lymphatic anomalies, some of them combined. The KHE is over on this side. We have people that have capillary malformation, arterial venous malformations, but also the Parkes-Weber has a big lymphatic component to it. We know that KLA has NRAS mutations. So we know that we have a lot of mutations that are on this side, including the central conducting anomalies and including Noonan syndrome that has a lot of lymphatic anomalies. So this is some information of patients that were taken care of here at CHOP, where their mutation was identified and they were treated with a medicine called trametinib, which is on this side of the pathway. And this was reported by Dr. Harkonnerson, who runs the Center for Applied Genomics. And he found an ARAF mutation in a patient that had a central conducting anomaly. And you can see this patient had significant lymphedema. And these are pictures of an MRL with a significant just array of abnormal lymphatic connections in that area. And what was found was that the lymphedema improved, but also there was remodeling of the lymphatic system after this patient was put on a MEK inhibitor called trametinib. The other important thing was there is improvement that was seen in pulmonary function. So a lot of times we have patients that really have systemic elements to their disorder, and so that was an incredible improvement. This is a second case of a patient that has a Caposiform Lymphangiomatosis. This is a patient that was treated by many of us. I was her treating physician for a long period of time. KLA, her disease was mostly in her lung, and you can see that she had effusions. She had a significant conducting problem from that. She had soft tissue disease. She had such restrictive lung disease and shortness of breath that she could not walk down a hall. We got to the point where she needed treatment when we did not know she had a genotype because we couldn't find one. And she was started on trametinib here in Philadelphia. And then her lymphatic fluid was evaluated by Dr. Harkonnerson, and she was found to have a CBL mutation, which again is in this RASopathy pathway. She was started on trametinib, and 2 months after she was started on trametinib, she actually ran a 5K. So this is our picture now, which again, this picture gives me goosebumps as well, because you can see that now we have phenotype, genotype identification, and we know where we can hit patients with medicines. And we need to look more at other medical opportunities. We also need our basic scientists to help us with the mechanism, so why things are working and what other possibilities that we have. So I'm going to talk a little bit about collaboration. And collaboration is so incredibly important. We are very lucky that we have the Center for Applied Genomics here. When I was in Boston, we also worked with the Broad Institute. Håkan Herkonarsson's lab with Sarah Shepard and with Dong Lee can enable us to look at germline and somatic mutations. We're doing digital droplet PCR. We're also doing cell-free DNA. And we are working with collaborative with scientists all over the country and really all over the world. Elisa Boskala was a scientist that I worked with in Cincinnati that we continue to work with, all of us, all of the groups. And she has animal models for vascular anomalies. Tim Kripe or Tim LaCroix worked with me on the original sirolimus study, and we roped him into becoming a scientist that's really focused now on lymphatic anomalies. He's very focused on KLA, and angiopoietin has been very important to us. And then, I can't give enough kudos to Michael Dellinger, who has really focused his career on looking at lymphatic anomalies, and he has mouse models too, specifically a mouse model for Gorham-Stout disease. We now have a consortium, so it's made up of 16 sites in the United States, mostly geared towards hem-onc, but in the spring we'll be opening it up so that other specialists are involved in this as well. CHOP is the administrative and also the data bank for this, and we're very excited because we will be running trials through Canvas. This is what what I sort of think a center of excellence looks like. So this is what you have at the bigger programs where you have a leadership team, you have a really core staff of specialty physicians that are taking care of your patients, but every single specialty, whether it be in pediatrics or adults, has to be represented. You need a support staff, you need a good clinical staff, you need your research team, and you need your basic scientists. So I'm going to hand this over to Kim, who's going to talk about her story, and this is her wonderful son, Michael.
Thank you, Denise. Next slide. First off, I'd really like to just say thank you, Dr. Adams and the Lymphatic Education Research Network, for this opportunity. What I'm hoping today to accomplish is to share with you our family story, as seen through a patient's family and also a physician. So you might ask, and I've put up here a picture of me in the operating room, why is a minimally invasive and bariatric surgeon doing a talk with a world expert in vascular anomalies and this amazing hematologist like Dr. Adams? And as Dr. Adams mentioned, our 11-year-old son, Michael, was diagnosed with Caposiform Lymphangiomatosis at the age of 6. And so here I am. And while the journey has been tough, daunting, scary, I just want to mention how lucky I feel to have had the opportunity to meet Dr. Adams and all the other doctors. I've learned so much clinically, which has been key for our son, and also professionally for myself as a physician. So here it goes. This is our story. Prior to medicine, I was an ice dancer. I skated and performed around the world. I ruptured my Achilles tendon and I returned. I was sidelined and I went back to school to be a doctor. Little did I know that I would end up in surgery. And I met this amazing surgeon who took amazing care of her patients. She was strong and assertive and passionate and never wavered about her decisions. And I wanted to be like that. So I fell in love with surgery, and despite how brutal it can be, because we have to admit it can be, I did my 5 years of surgical residency at Penn State. And while I was there, my best friend felt very badly for me because I had no social life and hooked me up to Match.com, and there I met my now husband, Greg. And I headed to Baltimore. Where he was an internal medicine doc at Hopkins, and I started my fellowship at Johns Hopkins. I moved to Baltimore and met my husband, and we got married. But as this says, career came first, and we were very much entangled in our work, and I was working a lot of hours. And my husband said, "Why are you putting pictures of our marriage up here?" And I think I need to share it because we didn't think about kids or a family. I was a hardcore surgeon and had not considered it. In fact, administrators, my chair, bosses said, if you have a kid, you're not going to be as good a surgeon. And so I went along with that for a while, but eventually did decide that I wanted to be a mom. And we tried to have kids and had trouble. So we had to do IVF. And after a few rounds, we were absolutely lucky and blessed to have Michael Alexander Prokopowicz. He was born on May 13th, 2009. He was 8 pounds, 5 ounces, and he was happy, healthy, and super smart. And I put this picture up of Michael because this is just after birth. And I was looking at him going, oh my goodness, I did this with my husband. Now what do I do? He's beautiful and I'm afraid. Well, we had a wonderful early childhood. Michael was, again, developing. Greg and I, as you can see, were trying to get sleep whenever we could. Michael just was bright and wonderful. And 4 months after having Michael, I started more IVF because we wanted another child. And Matthew, this blondie here, came as a super surprise without IVF. So we were blessed with 2 beautiful boys, 14 months apart. However, Michael, at the age of 5, started to have really concerning symptoms. I got called from clinic that Michael had a fever of 104. I took him to the pediatrician, and the pediatrician said, oh, Kim, it's probably a virus, sent us home. And then 2 weeks later, he started to have a rash. He continued to have these fevers. He was complaining of bone pain. And one night while he was in the bathtub, I saw that he had this huge swelling in his groin and scrotum. I called the doctor and they thought, again, maybe this was viral. He then started to have poor appetite. The doctors thought maybe it was behavioral. He had fatigue. And then this picture of him is coming home from school with all of these just crazy bruises, even if you touched him. So we started to look for explanations, and being a professional, a medical doc, I had access to that. My husband had, and I reached out to everyone that I could think of. And we went to hematology. We went to urology, who thought this was a hydrocele. We went to orthopedics because when he had bone pain, we took pictures and we saw some osteolysis in his right hip. And scoliosis, and it didn't make sense. We went to endocrinology, rheumatology, neurology, saw GI, who even thought maybe this is cystic fibrosis, pulmonary, cardiology, nutrition, physical therapy, and occupational therapy. No one knew. We also went down to the NIH. So just to go, we had to decide about watchful waiting versus additional testing and intervening. And our primary care, our peds doc and hematology really felt this was a viral infection and that he had idiopathic thrombocytopenia due to parvovirus because his antibodies were positive, but he wasn't improving. And so he also had this swelling in his groin. They thought it was a hydrocele. So at the same time, they felt, let's do some IVIG treatment, take him to the operating room, fix the hydrocele. And at this point, because the IVIG did not do anything, they felt a bone marrow biopsy was necessary. This was right before Thanksgiving, and we got the news from our hematologist that the the pathology showed an aplastic picture or hypocellular picture, and they felt that Michael might have aplastic anemia. What was really hard for me was sitting in the waiting room waiting while the urologist, who was a friend, operated on the hydrocele. The case, which should usually take 30 minutes, took over 4 hours, and when she came out of the operating room, she was pale. And she explained that all she had was blood and that it wouldn't stop bleeding, and there was no hydrocele. So what we had to do is entertain many scary diagnoses, and this was considered over 12 months. The doctors decided we needed to send panels out for aplastic anemia, and really it was scary. You know, they were talking about Fanconi's anemia, all kinds of diseases that are here. Luckily, the genetic panel did come back as negative, and when we went to the NIH, the doctor there, who is a specialist in aplastic anemia, couldn't figure this out. And our hematologist said, well, maybe if we don't know what this is, Kim, no worries, he'll be off to college. And they did let us go for a family trip to Michigan, and here are my boys. We were having a great time 2 days into it. However, Michael bumped his head, and we don't even know how he did it, playing. He came to me and he had this small goose egg on the side, right side of his head, and it just rapidly expanded. And I, as a surgeon, didn't know what to do. I couldn't stop. And I wrapped his head like a mummy, as in this picture. And then we urgently saw a local hematologist who tested his platelets and fibrinogen and noted that they were low. She sent us home because the CT scan for any internal bleeding was negative and told us he'd be okay. Well, overnight, he wasn't okay. The pain and swelling worsened. He was vomiting. He had severe pain. And so we drove him to the University of Michigan. We rushed him there. I will say I've never been so afraid in my life. We spent 8 days at the University of Michigan. Michael became seriously ill with DIC, disseminated intravascular coagulation, that they couldn't explain. He was receiving blood transfusions, and at one point they felt maybe this was a lupus-induced picture of aplastic anemia and started him on steroids. We saw multiple consultations and specialists at Michigan who were wonderful, but no diagnosis was made. At one point, they did a fast exam because he was bleeding, and that's where they look at his belly to see if there's any blood, because it didn't make sense. It was coming from the head bump. And they saw some really weird vessels at his gallbladder, which they had seen before, but had told me when I asked about it that it's just aberrant blood vessels. Well, it turns out they decided to do an MRI on the last day of our hospitalization. They didn't let us know what they saw other than fluffy infiltrates in the belly, and discharged us back to home for further care. Well, we got home, and I'll never forget the day. I put the kids to sleep, and Greg, my husband, went on to Epic, because we can, and saw the report of the MRI. And we didn't know what this meant. It said diffuse lymphangiomatoses. And as a surgeon, it scared the life out of me because it described it wrapping around the SMA, all throughout his abdomen and a little bit in his chest. And when we Googled this, because that's what we did, it said that it had a poor prognosis, no cure. It was characterized by slow progressive growth of the lymphatics, and that there were pilus infusions involved, and that it might be associated with lytic bone lesions and mediastinal compression. So if we think back to that bone marrow biopsy, they had gotten into some of this lytic bone disease and diagnosed it incorrectly as aplastic anemia, which took us down the wrong path for almost a year. Greg and I, at that point, did everything we could. We looked online for anyone we thought might help and sent emails. And I reached out to every friend and doc I knew. So what was so cool was the outreach was met with really quick response. We were so grateful and so lucky. I first went to Patricia Burrows, who was at the Medical School of Wisconsin, and I told her my story. And then she put me on to Dr. John at Sick Kids and told my story. This noting, it's all on July 7th, 2016. And within like a few minutes, Dr. John wrote back. He said, because you're not in Canada, you should try Children's Boston Hospital. And I think he put me on to Dr. Steve Fishman, knowing that I was a surgeon as well. Well, within a few minutes, I received a call from Dr. Fishman, and we spoke, and he felt that this is diffuse lymphangiomatous and was going to reach his colleague, Dr. Denise Adams. And that's when I reached out to Dr. Adams on July 8th, 2016, and have known her since, and so grateful. So Dr. Adams said, as soon as Michael's stable, get him to the hospital. We took him to Boston Children's, and she confirmed that this was Caposiform Lymphangiomatosis. While we were in her office, she did recommend that we go home and have a biopsy. I wanted to stay in Boston. I was ready to just stay with her. She said, no, go home. They'll take care of you. So in the bottom picture here, Michael did undergo a biopsy. We started him on sirolimus. We learned about troughs, and I also learned about PK studies that can be done so that we can measure the dosing, and understood the importance of the dosing with sirolimus. Most importantly, I heard the words of wisdom from Dr. Adams, who said, please, don't read about this right now. The literature is pretty tough. Take care of yourself and your marriage. And she also gave us names of specialists. The way that my husband, Greg, and I really dealt with this the best way we could was, he's the kind of intellect. He read all the papers because I couldn't, and he would give me names of people that I would reach out to without hesitation for help. I also asked Dr. Adams what research was being done and how I could help. And all of that came from my background, I believe, as a surgeon and researcher. So what happened with Michael was, after we tried to come down with the steroids and use the sirolimus only, the platelet count just dropped. It plummeted as we tried to get him off the steroids. And the steroids were started actually because they thought he had lupus. But he was on such high doses, and as we came off, his platelets dropped to about 20,000. I tried to convince the doctors to give him pulse dose steroids, but that did not work. It brought them up a bit, and then it dropped again. And at that point, Dr. Adams really said we should be trying vincristine to try to get him off of the prednisone. So just for those parents and patients out there, vincristine, it's a chemotherapy drug, and usually you need a port. Michael's platelets were so low, and me being a surgeon and knowing complications, I was afraid of a port. And then the idea was maybe to put a PICC line, which could help, but Michael loved to swim, and that was the only kind of activity he could do. So I convinced the team to try giving it through an IV, which was kind of crazy. And I was looked upon with some 4 eyes, but we did it. And this shows our Michael. We had a routine. Michael would come in, he'd have freezy spray and some numbing medication and warm packs. Then Miss Allison, who is our infusion nurse that we love dearly, would get the IV in for Michael. We'd send labs, and after the labs were confirmed, we'd go up to the pediatric oncology unit, and Miss Emily, his oncology nurse, would drip the vincristine into the IV. It was a 5-minute drip, and then we would go home. And you see, Michael took it all really incredibly terrifically. The nice thing about it was that the vincristine did allow us to get off the prednisone. And Michael rang his bell after his chemotherapy, and we went on to discover that Michael now had scoliosis. And he had to wear this TLSO brace. Now, again, you see Michael, he's fine as long as he has his device at his iPad. What led us to the next step in his care, though, really was about the LGDA Facebook and the parents on that Facebook page. I couldn't go on it. It was still so hard for me to read the things because I wanted to help these parents. So Michael was diagnosed with scoliosis, and I was explaining that my husband read on LGDA Facebook from parents who know so much that in Gorham stouts, bisphosphonates were being used. We reached out to our orthopedic surgeon and also our endocrinologist, and they said it couldn't hurt. We were concerned about Michael having some microfractures because he did have some limited bone disease. At that time also, when we were going to start the bisphosphonates, I remembered that Dr. Adams talked about Dr. LaCroix, who she mentioned earlier, and he was studying biomarkers, and our endocrinologist was also interested in biomarkers, and I said, what the heck, I'm going to pick up the phone and ask if we could be a part of this. And Dr. LaCroix has been incredible, amazing. And he and our endocrinologist, Dr. Janet Crane at Johns Hopkins, Dr. LaCroix at Cincinnati Children's, worked together. And Michael was in this study where they drew blood during his bisphosphonate treatments and measured the biomarkers in his blood, including angiopoietin-2. And what they discovered, I don't have the graphs here, but what we saw clinically was every time that Michael had this alendronate, he would bruise a little bit the day after, but then those bruises just disappeared and he was terrific. He had great function, he was playing, happy, and the bruises were not there. And each time he got an additional dose, it improved. And so what they did was document this. What we found was that there was some type of synergy between the sirolimus and the bisphosphonate, we used Zometa, and that his platelet count rose. So with the vincristine, we got to about 60,000 and hovered there for his platelets. But with this treatment, this combined treatment, I can now really excitedly tell you that Michael's platelet count was 249,000 in October, and his fibrinogen 272. So we know that there's some underlying mechanisms going on. We just don't know what. And I worked with these doctors and really encouraged that we get this case report out there for other doctors to know about and hopefully do more science. We also noted that Michael's angiopoietin-2 levels became normal after being skyrocketed. So this was incredible, and we're hoping that this potential single case report will inspire others to do some clinical trials and find better therapeutics. Why this page? This is a list of all of the researchers and clinicians worldwide, just a few that I have reached out to who have responded, and including the Lymphatic Education Research Network, who has been so supportive and advocating for improved lymphatic disease research and funding. And of course, the LGDA, where now I have become the Director of Patient-Led Research. And again, this is a thank you list of just so many who have been responsible, both clinicians and scientists, to get Michael to where he is right now. What are the lessons learned? And this is the last from me, but what I wanted to share with you, and I was nervous today, I give lots of talks on my respective expertise in obesity. I was nervous because what I hope, this is the most important talk I'll probably give, because I'm hoping that I can reach out to both the the pillars, the scientists, the clinicians, and the patients and families, that when we come together and collaborate, it's just incredible. And so many wonderful things can happen just from one individual patient. And I think that's what speaks so wonderfully about Dr. Adams' experience with the power of one. So the lessons learned, I think, are diagnosis can be difficult, even for those with a medical background. Social media, and that was us, social media can bring vital information to patients with rare diseases and their families, as it helped us. And clinicians and researchers can benefit from the patient community. And I think we as physicians need to respect the patient's, thoughts and hear them out, because they can give us so much crucial information. Finally, what is the power of the patient's voice? I believe an individual can catalyze important clinical and scientific collaboration. And these are my kids, and I do believe sharing our story, Michael has been a power of one. We, the community, can and should contribute to patient care and research. And so again, reaching out to all of the families, all of the patients, bring your skills, whatever skills, it doesn't matter, and help us do this fight. I believe, anything that you can do, joining registries, joining the research, volunteering, with these steps. So we want it to be a race because there is urgency for us, but it is a marathon. And with these incremental steps that we can all do together, we can really accomplish great things. So what I say is, each of us, please, whatever skills you have in background and experience, bring it forward. And you can reach out to me if you don't know what to do, and I am sure I will find some things that you can help us with. Finally, for the docs, we all learn, and as a surgeon, this is what I learned: when you hear hoofbeats, first think horses. But please don't forget about the zebras, because sometimes it really is a zebra.
Oh, that was amazing, Kim. Thank you very much for that. Yes, we can go ahead and take some questions. I'm seeing some also in the chat box. If we put them in, I forgot to mention this in the beginning, in the Q&A, that would be better. I did see a question that came across though about registries. And I do think we need natural history data. So the LGDA and also some of the other vascular anomaly groups are part of something called the CZI. I don't know, Kim, do you want to talk about that a little bit? Because, someone is asking what registry should I engage in?
Okay, I didn't hear the part about the CZI, but with Michael, we have put him in every registry that we're able to put him in. What I hope as a parent and as a physician to discuss with the researchers is to bring this data together. We really need to do that. And I think Dr. Adams is working on that. But in the meantime, if you have the time, please make the time and the ability. The registries are important to sign up to. So I do know that Boston Children's has a registry for vascular anomalies, and then go to your respective advocacy groups. So if you have a complex lymphatic anomaly, please sign up to the registry on the LGDA organization. I can also tell you that I have worked with the LGDA now to partner with All Stripes. All Stripes is a group that is collecting patient data for us. And I think it's fantastic because we don't have to do the work. And the idea with this is to accelerate drug development. It's de-identified. And what they're doing is bringing the pharma companies and the researchers together to accelerate drug development. And so I'm promoting it like crazy. I know that Cloves syndrome community is also going to be joining All Stripes. So it's a real positive for all of us. The other thing is that the Lymphatic Education and Research Network also has a registry. And so again, we're signing up. I think again, it's important. Give your information. The doctors learned from us, and our experiences help them make these discoveries. So I think that's really important. The only other thing to explain about the Zuckerberg initiative, the Zuckerberg initiative created a Rare as One campaign. They put out an RFA where they hope to cure all rare disease by a certain date, I don't know, 2050. And so they put out an RFA to rare disease groups. The LGDA did apply and were one of the grantees, as well as the Cloves Syndrome Foundation. And in that grant, the goal is to have patient-led research and to create research networks where we are collaborating with the doctors, the patients, and the scientists. And that's what we're starting to do. So come join us.
Great. So I'm gonna try. I have some time, so we'll try to keep going with the questions. Can everyone hear me? Okay.
Yes.
Some of these questions are, specific to patients. I'll try my best. It's hard to give. We can't really give medical opinions over this, but we'll try. So, and I know this can be very frustrating. So the first question is a 47-year-old, and her mother is asking, who has what sounds like a veno-lymphatic malformation. So for the first thing is, it's really, really important now that we know the phenotypes to kind of understand, is this venous or is this lymphatic? In the past, a lot of lymphatic malformations were called lymphatic venous malformations because the veins are very much associated with the lymphatics, and we treat them in somewhat different ways. So really important to have someone look at her imaging. MRI is the best imaging that you can do to understand, are you truly dealing with more venous or more lymphatic? And there are places, so here at CHOP, at Boston Children's, I think at Cincinnati as well, we will review cases and do that for free. So if you go, because I know we're not as good with transition of care as we should be. We're really trying to get adult providers involved in this, adult, medical providers. We have some adult interventionalists, but we're trying to transition and do that in a good way. But in certain parts of the country, that's hard to do. But Boston Children's, I believe Cincinnati Children's, I don't know if Colorado Children's does, but if you go to their websites and CHOP where I am, if you go to their website, you actually can send information and for free have us look at it. Typically a physician to physician sort of needs to do that, but a family can definitely initiate that. And so the other thing is about your daughter is that a lot of people who have head and neck malformations, even lymphatic malformations in the mediastinum, I think many of them go through that route of, is this a malignancy or not? And sometimes people just are not aware that a vascular malformation is not a malignancy and it looks a certain way. As far as, do you need a biopsy or not? We need a biopsy if there's any question at all what the diagnosis is. And we are trying to figure out ways to link the phenotype to the genotype. But we have to be careful where biopsies are done. We never, never, never want to do a rib biopsy in a lymphatic malformation patient because you can develop a leak. So I would suggest that if you don't have those, that people where you are, that you can have her case reviewed by one of the larger centers. Then the next is a patient as well that, Proteus, that was diagnosed with Proteus patients. And so this is a patient from Brazil. So first things first is I would make sure that that diagnosis is correct. Proteus patients have AKT mutations. And so an AKT inhibitor, Proteus patients can have vascular anomalies, but an AKT inhibitor would be a much better drug for her if she truly has Proteus. But again, a lot of our patients have been misdiagnosed as having Proteus. So as well, there are also some centers that are in Brazil that are absolutely wonderful. I know that I'm talking about in particular a pediatric center. I don't know if their age cutoff is 21 or not, but I can certainly get that information for you in Brazil. And then we go back to like Gorham Stout, if a viral infection could reactivate Gorham Stout. And so we think of trauma, puberty, a significant virus reactivating Gorham Stout. The thing that I'm most fearful of with COVID-19 is that we don't really have a good sense of who's going to get sick and who's not going to get sick. And just as Kim talked about the so angiopoietin 2, that component that's high in KHE and KLA. You know, a lot of these lymphatic issues have a lymphatic component to them. And initially we were very worried about our patients, and we don't know who's going to get sick and who's not going to get sick. So much better for our patients to not have them get COVID-19. And so when the vaccine is available, we are definitely suggesting that they get the vaccine. But more information, if you go to any of the patient support groups and go to their websites and look at that. The next question is about diet. It's a patient that has Klippel-Trenaunay, which is a combined lesion. So typically it's a capillary lymphatic venous malformation. And side effects of sirolimus. So remember, the whole pathway that's involved, that PIK3CA pathway is a metabolic pathway. You know, some of the side effects are increase in cholesterol. Some of the side effects of the new medicines are also the same thing, increase in cholesterol. And I personally think that the diet is incredibly important. I also think, because that pathway is involved, that having a good diet and actually doing some research related to that would be very important as well. We find that some of our patients with the combined lesions and overgrowth seem to have some areas that are cachectic, meaning they're not getting enough nutrition, and others, you know, it's almost like the overgrowth area is stealing from the other sides. So I'm a big component for good nutrition, and I actually have all of our patients, or the majority of our patients who are on sirolimus, meet a nutritionist. That was, you know, that can be easier in some places versus other places. And then workups for someone with GLA. And so there was a very good article that was based with the LGDA, when the LGDA had a meeting, and it was the lead author was Yanela Iokabas. And so I wonder if we could also come up with references for you, but that basically had sort of what you do for workup. A patient at 3 months of age, so remember, generalized lymphatic anomaly sometimes is a term used when we don't know what else to call things. So sometimes you can have diffuse lymphatic anomalies, and that should be called a diffuse lymphatic anomaly. Every GLA doesn't have to have skin, bone, spleen, that kind of involvement. So really important that that phenotype is correct. So the next is a 9-month-old born with bilateral and upper, lower, and facial lymphedema, and albumin is low. So when we see patients with lymphedema, we right away, so swelling, wonder and whether someone has a problem, and I'm going to call it the plumbing. So that's the conducting system. And the best way to really figure that out is to have someone look at labs to make sure that the proteins are okay, and also to have someone look at labs that make sure that the GI tract is okay, because there's something called protein losing enteropathy. There are other studies that can be done. So here at CHOP, we're really fortunate that we have our vascular, so it's a Comprehensive Vascular Anomaly Program, but we have a big lymphatics program, and we work hand in hand. We're like siblings that we work together to take care of patients. But they do a lot of work with the plumbing, with the central collecting problems. And so there are ways that needs to be looked at. So see at your site, wherever you are, if there are experts in lymphedema or central conducting problems. The next has sort of a lot to do with lymphedema care. Very, very, very important to go to a place that has lymphedema specialists, that has, like the specialists that I talked about that we have at the lymphatic team. Salivary ducts can be affected, if your lymphedema is facial, and depending on what is happening, you actually can have impact on other organ systems. We have a physical therapist and an occupational therapist that are experts in lymphatic massage, also in dressings and lymphatic compression. That is absolutely necessary. I know that so the group here, there's other groups, Aaron Green, the group in Boston. So there are other specialists. Actually, the LE&RN group has centers of excellence. And so you might want to go to the LE&RN website to see where those centers of excellence are, because that may help a lot. Yes.
May I just say, in our experience, I reached out to a lymphedema specialist, and it really helped. Michael had all that swelling in his groin, and this poor kid, I was doing lymphedema massage. I learned how to do it, and it did help. We did it carefully, but it did help. And I think the thing from the parents, I would say, really seek out the experts, the ones that are at the centers, like Dr. Adams is saying, because I think it's really important that you get plugged into an expert so that when there is a situation, an emergency, that expert is part of the team to guide you.
Yeah. Thanks, Kim. Yeah, it is important, and I think this designation, these centers of excellence that are popping up are really quite good. So Johan asked about the ARF mutation and was that somatic or germline? And I don't know if everybody really understands the patients that are on what is somatic and what is germline. So germline means that you have something that's, so this is a very simple way of describing it, very simple. Germline means that you have something that is inherited. You have it from the egg or from the sperm. Sometimes people can have germline mutations that you can't find. It's sort of a genetic problem that happened and you can't find it in the family. But most of the time they come from the egg and the sperm, which means that they are in every single cell of the body. So they are in tissue. You can spit into a cup. I always remind my patients, like 23andMe, Ancestry.com, those kinds of things are somatic mutations, germline mutations. So sickle cell disease, cystic fibrosis, why you're prone to diabetes, all of those kinds of things. So they're much easier to find sometimes they're not. But somatic mutations are mutations that involve the area that's affected. So for example, everybody who's on this call, almost every cell in your body has that whole RAS1 PIK3CA pathway, because we have to grow. A cell needs to become a muscle. A cell needs to become, a blood vessel. And this is very simple, but in development, when some people are developing in a certain area, in a certain cell, some of that pathway might have just been wrong. And so that's where the somatic mutations come from. Somatic mutations are much more difficult to find because you can only do a biopsy. We're looking at something called circulating free DNA to see if something's circulating around in the blood. And the deal about our patients is that the percentage of the mutations that you see in that area that's involved is really low. It's not in every cell of their vascular malformation. So that was a germline mutation, Johan. But most of the mutations that we take care of are somatic mutations. So, about communicating, if anyone has a question, all of the LE&RN has the centers of excellence. Also, if you put vascular anomalies or vascular malformations all across the world, you can find where there are centers that if you have any questions. And again, that's where the information is on all of the COVID-19 stuff as well. The Venthura, so people are asking about the Venthura Drug. So Venthura has a PIK3CA inhibitor that is a topical agent, and that is used for a patient that has a vascular malformation that has a PIK3CA mutation. And you have to be able to do it on a very particular area to see if it responds. So we're trying to use more topical agents because you have less side effects from that. So someone can have a diffuse lesion, but they have to have one isolated area that they can use that medicine on. And then people are asking sort of about lymphatic disorders and lymphatic-venous or venous lymphatic bypasses and things like that. So lymph node transplants. So there are, so I know in Boston, they're doing some of these things. I think in Asia and Japan, really started all of those techniques through our lymphatic group. We're doing those techniques here, and I think probably the best thing to do is to look at, again, on the LE&RN site, those centers of excellences, to really figure out, you know, for that, to me, it would be who has the most experience and what your long-term outcomes have been. But I can tell you there is a lot, so we have scientists now that are working with us. We have specialists in every area. I'm very positive about what the future is going to hold in every area. So in therapeutic options, in surgical, in interventional options, we're also looking at drug delivery. So I think it's really, really important. So we're talking about, you know, like, when do we refer a patient for compression? So, you know, we have OTPT that's in our clinic. If anyone has a lymphatic malformation that has any bit of overgrowth where we think that compression would be positive, whether they're on medicine or not, I think that can be very helpful. The other thing that I want to say to you is we talked about two sides of this pathway. So we talked about the RASopathy side of the pathway. One of the medicines that we use is Mekinist. So this also can happen with sirolimus. So remember, we're using these medicines to take care of abnormal lymphatics, but in people who have these medicines and are using them for other things, like for cancer or like for transplants, sometimes these medicines can cause lymphedema. We're using them to treat this, but sometimes they can cause it. So I really do think that if there's any question of swelling or anything else, that a lymphedema and a therapist with expertise needs to be involved. For patients who genetically tested positive for PIK3CA and have been using sirolimus, are the newer medications to prove benefit? Okay, so this is a really important question, I think, because sirolimus is there. So what are the studies and what are we using them for? So remember, studies need to be used in a step-by-step fashion. We need to be very careful. We were very lucky that we were able to use sirolimus in a prospective way. So as far as these other studies, we have something called a managed access protocol with Novartis right now. Those are really for some of the most complicated patients that have PIK3CA, that has to be approved by Novartis to use it. It's kind of a fancier way than just having something called a single IND at your institution. There is a prospective Novartis study that will be coming out in the next couple of months. It will start with an adult-based population of patients because when things go through the FDA and the European Union that regulates studies as well, a lot of these studies are sort of first in these populations of patients, and so they really feel that adults need to be tested first. But very quickly, the pediatric age group will be included as well. There also will be a placebo arm. So placebo means that there will be some patients who get the medicine and some patients who don't get the medicine. So that's really the best way to do a study. Sometimes in pediatrics, we have a hard time with that because sometimes when our patients need the drug, they need the drug. And so that's kind of how we're doing this now. If you have any questions about whether you or your family member would be suitable for those drugs, I would go to one of those, the websites for the patients that the vascular anomaly centers. And then, is there a plan for trametinib to be in a clinical trial? Hello, Michelle. Nice to see your name as well. So yes, there is. So we have a study that we're going to be hopefully getting out here. Remember, studies cost money. We were very fortunate to get the first Ralama study funded. If there's anything that you all could do, it would be to lobby NIH and tell them the importance of vascular anomalies, also lobby insurance companies, because believe it or not, we're still having that problem with this. We're still having a problem with getting genetic testing approved. Some of these studies will require that there be some sort of mutation that is known, but we are going to hopefully have a study here. Our hopes are as well to apply for some funding that will have a larger study that is involved in Canvas, which is based on the genotype and the phenotype. So that will probably not be ready for another 6 to 8 months. Let's see. So this is about oral coagulation. So we did talk about that some of these patients will have coagulopathies that not only cause bleeding, but also cause clots. And sometimes when people are having surgical procedures and they're immobilized, they need to use anticoagulation. And sometimes for kids, like we have oral medicines that you might see when you're watching television that are available for adults. They are becoming more available for children, but not necessarily young children. They're just looking at the reports of that for like kids in that, less than 12 years of age. But very, very, very soon, there will be oral anticoagulants for those kids in that younger age. And then someone again is asking about the alpelisib and PIK3CA conformation. And for right now, you need PIK3CA conformation to get on one of the alpelisib studies. If someone, though, has a life-threatening problem, then you might be able to not need that confirmation. Okay, so then this is Juan Carlos, who's asking about the diagnosis between KLA and GLA with intralesional bleeding and wrong coagulation parameters. So I think that so this KLA that we talked about, Caposiform Lymphangiomatosis, has a very particular way that it looks on MRI imaging. And we did a study which is going to be out there soon, and it was presented at ISFA, which really looks at radiologic data sets that compare KLA to GLA to CCLA. So when we're trying to differentiate, because sometimes GLA, if you bleed into a lymphatic, you will definitely have an increase in your D-dimer. You might actually have a little bit of clot that's there, which can consume some of your platelets. You shouldn't have a low fibrinogen, but I guess if you had a really bad bleed, you could. And the problem also with KLA is sometimes so with KAG, when you have a coagulopathy, it is definitely a coagulopathy. Your platelets are low, your fibrinogen is low. With KLA, there's different, what I call risks stratification. So sometimes patients have a very significant coagulopathy. Sometimes they don't have a significant coagulopathy. Sometimes a KLA patient just has the typical appearance on an MRI, but maybe has a low normal platelet count and a high D-dimer, and that's all you have. So I think to your question, Juan Carlos, what we use to differentiate is the whole picture of the patient. And, you know, I have to say that sometimes there have been patients who have been diagnosed as GLA that really are KLA, and probably vice versa. So the best website for registries, well, I think, you know, I would start with LE&RN, I would start with LGDA. LGDA has a registry that's been around for a long while. For patients that have closed, and closed patients can have lymphatics, they have a great registry. So I think I would go to the websites that actually you know, are the again focused on the phenotype of who you're taking care of, and go to that and see if they have a registry. This is again about nutrition and adipose cells, which is tremendous. There's sort of a project that Stan Roxon is doing, and I think that's going to be really, really important. I think adipose cells in general, to me, are really important for us to do research on, because I think there is sort of some connection there. So then the next question is about sirolimus, hello Melissa, and everolimus. So there have been people who have tried sirolimus and have had side effects. So sirolimus and everolimus are both mTOR inhibitors. They both essentially work the same way. You know, they shouldn't have much of a difference, but we have found that sometimes when people are on sirolimus and have side effects, we can change them to everolimus, and those, they don't have as much side effects. So if I have a patient that we don't have a mutation for, so we don't have any other possibilities except for mTOR, and mTOR inhibitor has helped them, I do think about changing from sirolimus to everolimus. And again, talking about lymphatic massage, so actually for a lymphatic malformation of the face, particularly the tongue, floor of mouth, that's a tough area. I have seen some we have this amazing lymphatic massage person here that really, truly thinks outside of the box. So and we've had some plastic surgeons that also think outside of the box. So I think that's probably worthwhile to ask your lymphatic specialist. And you can even ask your lymphatic specialist to see if they could, if they don't know, talk to other people. Okay, thank you all.
Thank you. Thank you. And if patients' families want to reach out, please reach out. We would love to have you.